similar to the one that we had done, was it just last week, on placebo effect, but this time looking at it in terms of anxiety disorders. So very similarly, we're going to look at the symptoms of anxiety disorders just to, I think the breadth of what could potentially be improved is kind of impressive with this set of disorders. We're going to compare some efficacy data, and then we're going to look at some of the theories as to why they say that placebo actually works for patients with anxiety. So with anxiety disorders in general, I think it's important to set a foundation. This is one of the most commonly occurring psychiatric disorders. More than a third of patients will be affected within their lifetime. And in adults, more than 20% of them have had an anxiety disorder over the last year. It often happens in conjunction with other conditions, both physical and mental health conditions. And we have a whole range of diagnoses that are on here. So obsessive compulsive disorder got moved out of the anxiety disorder umbrella, so that one we're not going to talk about. And post-traumatic stress disorder has some of its own unique characteristics, so I left that one out as well. These, even though they are separate diagnoses, they tend to fall under a more consistent approach in neuropsychopharmacologic etiology, so it made it a little bit easier just to chunk these in. So from a symptom standpoint, as I mentioned, there's a huge variety of symptoms that we see with anxiety disorders. So there can be physical symptoms, things like abdominal pain or muscle tension, headaches. There may be actual anxiety itself. So the fear, the feeling of fear that's really disproportionate for the threat that's been encountered. I got back early this morning from a trip. So if you were encountering terrible turbulence in a plane that looks like it may be somewhat unstable, having some of these anxiety symptoms would be completely fine. Me sitting in this room with the sun shining outside and having that type of physical reaction would be disproportionate to the threat level that I'm experiencing right now. It may lead to avoidance in some cases. This tends to be really problematic and something I think we focus in on more with panic disorder, where they tend to withdraw to the point of maybe they don't even want to go out into public anymore. But as you can see, there is a huge range of things from heart palpitations and sweating to sleep changes and concentration difficulties. So as we look at the rating scales for anxiety, it really takes into account all of these that the patient may be experiencing. And since anxiety tends to really diminish quality of life for patients, it's important that we really look at the whole picture and not just some individual ones. So from a treatment standpoint approach, there are two main initial focuses. So non-pharmacologic therapy is your psychotherapy. It could be counseling, meditation, cognitive behavioral therapy, and then also the pharmacologic agents that could be helpful. So these are our antidepressants. Short term, we could use some of the antihistamines or even benzodiazepines in certain cases. So as we look at these, the focus obviously is on the pharmacologic side, but it's teasing apart the active treatment versus the placebo treatment and the responses that we see to both. And I found this, I was having a tough time transitioning. I like my lectures to be a story and a narrative, and I felt like the transition was bad. So I was looking for something, and I came across this, and then I realized how well this pictograph aligns with the theories we're going to talk about at the end. And I should have done this with the depression one, so I apologize. So the placebo effect. It's implied that placebo is an inert substance, but that's not necessarily true. It's trying to determine if the active component of a drug makes a bigger difference than just the act of physically taking something and going to see a healthcare professional. But the act of actually taking something and going to see a healthcare professional in and of itself, that may have a role as well in how patients perceive their symptoms and how well that they're doing, as well as how empowered they feel in trying to seek out therapy. And that's where some of the rationale comes in. So this is a little bit of a spoiler, I apologize. But there are going to be some folks that if they believe that this is going to help, as you see the red arrow that comes through, then it doesn't matter if it's a placebo pill or not. They do believe that they're doing something and they get better. What was supposed to be the opposite side that I found way more in the anxiety placebo literature than I did in the depression placebo literature was this concept of nocebo. So placebo comes from the Latin that's I will help. Nocebo comes from the Latin of I will harm. And it's something that may actually do the exact opposite. In one of the articles, it called it placebo's evil twin, the same side of the opposite side of the same coin. And it's believing that a substance, even if it doesn't have an active mechanism, will do something detrimental. It's not going to be helpful. I guess I would challenge both of you, as well as those around the table. I would imagine you'd be able to think of a patient who really didn't believe that whatever they were getting was going to work. And that may be as simple as, you're telling me I have a cold, and you're telling me to use antihistamines and hot liquids, and I don't think that's going to work. So you know what? That person probably isn't going to feel any better in 2 or 3 days. Whereas someone who believes that, okay, maybe that is what it is and this is what I need to do to feel better, may actually start feeling better despite the fact their symptoms don't change whatsoever. And that may lead to dramatically more dire consequences. In this case, they have it as a coffin, but not often are placebos fatal. So that's a little bit of an extrapolation, but I thought it really set up the concept incredibly well. So we're going to come back to that a little bit. But I thought to start with, if I'm saying that there's a placebo effect in anxiety, I wanted you to go off of more than just my word. So we're going to look at 3 different trials, because this is supposed to be a blitz. So by no means is this comprehensive, but it's just a quick tour through some of the literature. So this was a 10-week randomized double-blind placebo-controlled trial in adults that had generalized anxiety disorder. So this is one of the sertraline trials that helped with its approval. 326 patients, they were moderately anxious, and they were following the Hamilton rating scale for anxiety, the HAM-A score. So just as a reminder, there are 14 categories. It can be scored from 0 to 56. Your cutoffs, if it's under 17, it tends to be mild symptoms. If it's above 17 to 24, it tends to be moderate. And if it's 25 or above, that tends to be moderate to severe anxiety. So these patients, their baseline score, and I'm cheating, I'm slightly sleep deprived, so I am cheating, I apologize, is 24. So they were moderately ill.
That's not cheating, that's
at baseline. It was preparedness. So they were able to have flexible doses of the sertraline over time. And what they found in the first column of bars way on the left-hand side is that there was a change in your sertraline group by 12 points and a decrease in the placebo group by 11 points. And even though statistically that was different, it was a relatively robust diminishment of anxiety symptoms for both groups, even the group that had placebo. When they looked at their responders, so those that their scores decreased by more than half, almost 60% of the sertraline patients and just under 50, so just under half of your placebo patients had such a robust response that their anxiety symptoms dropped by 50%. So not inconsequential. The other finding that they had that I wanted to put out here, because we will come back to it in another trial as well, is the clinical global impression of improvement. So 1 or 2 being much improved or very much improved. So that as a clinician, you're looking at the patient and yes, this is clinically significant because I think you're better. I see that you're better. And that was more than half of the patients in the placebo group. So in just looking at this one, that placebo group, even though sertraline was statistically significantly better, there was a definite clinical response in those patients that had that were just administered the placebo and then followed up with their providers throughout this 10 weeks. So is that an anomaly? The answer, I think, is no. Here's another look at generalized anxiety disorder. I wanted to give you other treatment options and not just the antidepressants. So this was did not put, so this had a couple hundred patients in it as well. I did not finish the N in that one, I apologize. But they were split into a bunch of different groups. So 3 different doses of pregabalin, then alprazolam or placebo. They were followed only for 4 weeks. And usually we tend to need to see a longer period of time, especially with the antidepressants. I'm going to come back to that with the theory here in just a second. But this was randomized, double-blind, placebo-controlled. And again, their primary outcome was that change in the Hamilton A rating score, with responders being a reduction by 50%. So starting on the far left-hand side of the column, you see the change in that score. And statistically, most of the medications did have a large, well, numerically they all had a larger reduction. Not all of them separated from the placebo group, but even the placebo group had a reduction of 8 points. Their baseline score of the HAM-A was 24-25. So again, some of the more moderately ill patients. When we look at the responders, again, we see a third of those placebo patients. That light blue bar is our placebo group. A third of them had more than 50% reduction in the HAM-A. And then again, on the CGI, where they look like they're better, a third of them still look like they were better. So outperformed by both pregabalin and alprazolam, but not a negligible response. So there still are individuals who were responding to this. And I guess I want to point out, at 4 weeks, that's a pretty significant response to say a third of those patients were better already at that 4-week time frame, which is a little bit unusual. Last evidence I wanted to look at was in panic disorder. Just to look at something a little different, the social anxiety and specific phobias got a little bit more complicated. This was just clean because methodologically it was consistent with the other 2 trials. So 8-week randomized double-blind placebo-controlled parallel group. So this is alprazolam and imipramine with placebo. Smaller sample size, but they were looking specifically at older patients. So individuals who are 55 years of age or older. And in this case, they looked at both the self-report of anxiety as well as a number of different clinician-reported outcomes. I pulled out the Hamilton A because that was what we've been looking at. In looking at these with the Hamilton A scores, they were not quite as severe. So they were more mild to moderately ill. Again, it was some of the older patients. At the end of the 8 weeks, you didn't see as big of a reduction in that placebo group. So their Hamilton A dropped from 20 to 15. So it didn't really look like we saw that big robust response that we had seen before. But when they went back and looked at tracking the number of panic attacks per week, at baseline, the placebo group had about 3 panic attacks a week. By the end of 8 weeks, they were down to 0. So even though the Hamilton A rating did not decrease, some of the patient rating scores did increase, and the number of panic attacks they were reporting increased. So again, still there is a signal that there is some type of response in these patients who are just receiving a placebo. Now, why does that happen? Well, that's a really good question. I don't have a definitive answer, but I can tell you some of the theories that are out there in the literature. So one of the main prevailing ones is that placebo does result in an improvement in symptoms, a reduction in symptoms. The primary factor, at least for anxiety patients, seems to be the expectation of symptom improvement. So a past experience. So if I had an anxiety disorder previously, I was treated with an antidepressant, I got better, it went away, I went off it, my anxiety came back. If I'm reintroduced that, I had a positive experience, my expectation is that this is going to work. Therefore, I may be more likely to start seeing improvement and having more of a positive thought narrative along those lines. There may also be some contextual clues, and I think this is super interesting because they could be conscious or unconscious. So Conscious would be that if you're working with a patient and you honestly believe that you have all these patients and all these relatives in your family that had anxiety disorder, everybody responded to paroxetine, I believe this is going to work for you. That may be a conscious bias where you're really setting it up for this is effective, I think this is going to work. So there may be some alliance there where, again, starting to set those expectations that this would be positive. Unconscious may go in either direction. I'll use the opposite example, but of I'm not sure this is anxiety, I'm not really sure medication's going to work, and maybe you don't say anything overtly, but some of those unconscious clues, even nonverbal behaviors, may be enough to signal that this isn't going to be effective and therefore we don't see a response. And again, it can go the other way to say, you may give some of those hints and they do see that response, but I couldn't think of a good example of that with unconscious bias. So that seems to play a role, and there are some studies, interesting studies that they've done that look at that. Another piece is that biologically there may be some traits that modulate somebody's response to placebo. So they are looking specifically, this came from a pharmacogenomic journal, I'm pretty sure, the citation's covered up here on my screen, but they believe that there may be some genetic predisposition to responding to a placebo. They're looking at a whole bunch of genes. The data really is not robust right now. It is a theory that's out there, but it's interesting to think that maybe genetically there might be something there to say, we don't really need much, but you need to be taking active steps to try to get yourself well, and that may help assist with some of your anxiety symptoms, which might be powerful if somebody thinks that, hey, taking my multivitamin every day is enough to help with my anxiety symptoms because it's part of a treatment regimen. And then from a risk-benefit standpoint, that might be really different than having to weigh out the benefits of taking something like a benzodiazepine or another medication. There was a couple others, and I wanted to highlight this one before I close, just because this one really built on each other, and they used some different terminology. So this talked about other theories of placebo response, and there's a couple articles that have a whole list of them. So this is by no means conclusive, but I thought this was a good way of showing how they could build on each other. So that expectation model we just talked about, a self-fulfilling prophecy. If I think this is going to work, then likely we will see some improvement. The next one is something called a reflex or Pavlovian model. And just brief aside, when I was in school, my dad, when I came home and I was asking about what he learned about Pavlov's dogs, he told me he didn't learn about it, that they were pups at the time. That is not true. So every time I see that, I think of my dad. So if you remember the Pavlovian model, they would ring the bell and feed the dogs so the dogs would salivate, and it became a reflex. It could potentially be that it's learned response. Going to the doctor, taking a medication becomes a learned response where you believe that you'll get well. So that may be more of a habituation than even expectations, because it's actually just a response, a learned response that you have. So slightly different, but you can see how they're very similar. And if you have positive expectations and the learned response, that could potentially be synergistic to improve some of those symptoms. The other one that they pulled out I thought was a little bit of a stretch. So I did some digging, and I'll put it out there as a theory because it hasn't really been proved in either direction. But just the act of taking a placebo may be a stimulus, or has been shown to be a stimulus to release endogenous endorphins, similar to an opiate. Not to the same extent, but it does release some endogenous endorphins. Some of the theories behind that are that there is some relief in saying I have symptoms and I am taking active steps to get better, and there's almost relief in the action of doing so, or positive reinforcement for this is a step toward trying to get better. That I had a really hard time differentiating from that reflex model, but those endogenous endorphins can then cause positive reinforcement to then potentially be synergistic with the other two models. So it's interesting. They're looking at neuroimaging in patients who are taking placebos, so those that have symptoms, and they're seeing changes in brain activity in different areas consistent with changes in the areas of brain activity in other patients who are on active drugs. So could it be that their disease is just getting better? Absolutely. Could it be that at least in a short-term trial, something like a 4-week trial, there is improvement because patients may perform better because it's kind of novel and different and unexpected? Absolutely, it might be that as well. It may also be a regression to the mean. So some of those patients that have relatively severe symptoms, eventually they likely will come back to the mean. There's a small percentage that will not, but the vast majority of them will bring their anxiety scores down. So there may be a number of other factors that are involved, but it's just interesting to think about the fact that it may not just be a medication that could be the answer for some of our patients. So to summarize, there are a significant number of patients with anxiety that do respond to placebo therapy. So I gave you 3 examples, and we're looking at a third to almost half of them did have some significant amount of response. Most of them were not refractory patients, for the record. So I do want to make that distinguishing factor. I forgot to do that as I was talking. The theories do suggest that there's a significant role for expectation. So that may be something to think about when you're doing shared decision making and talking about treatment options. But there may be other factors that play into it as well, including your response and the way that you even introduce some of those treatment options to the patient. And with that, I will close.